My name is Becca Miller. I'll be your moderator for the next hour, and I'm thrilled to be joined by our presenter, Dr. Daniel Weintraub. Dr. Weintraub is professor of psychiatry at the University of Pennsylvania School of Medicine and psychiatrist at the Parkinson's Disease Center at the Philadelphia Veterans Affairs Medical Center. He's a board-certified geriatric psychiatrist, and he also conducts clinical research in the psychiatric and cognitive complications of Parkinson's disease and related disorders. Our session today is going to be him talking about the psychiatric and cognitive medication side effects in Parkinson's disease. We're so pleased that you've joined us here today. If you're not already aware, there are 9 talks in this virtual YOPD series, each falling under one of 3 categories. The individual track, talking about living with Parkinson's. The in relation track, focusing on the importance of relationships since the impact of PD is so broad. And then the medical track, where we're focusing on the medical management of Parkinson's with a focus on YOPD. So this talk falls under that track. And not to worry if you miss a session this week, because we're recording them and they'll be available by Monday next week for viewing. During this session, you'll notice a box on the right side of the screen with 3 tabs, a question tab where you can submit questions at any tab, and a resource tab where you can download various resources that are mentioned in the session. There aren't any specific resources for this session, but you can find the resources from all the other sessions under that tab. So lastly, I want to thank our generous sponsor, Mitsubishi Tanabe Pharma America. We wouldn't be here today without their generous support. So now we're going to go ahead and get started. So Dr. Weintraub, take us away.
Thank you, Becca. So I'll wait for the slides to come up and so it should be one slide before that. And should I proceed now or wait for them to come? Okay. So hello, everyone. I'm Daniel Weintraub. I'm a psychiatrist at the University of Pennsylvania and also at the Philadelphia Department of Veterans Affairs. I'm a clinician researcher. I focus on the psychiatric and cognitive aspects of Parkinson's disease. And I want to thank the WPC for this invitation to present today. That I've gone to many WPC meetings now over the years, and it's really been a highlight for me in the sense for a couple of reasons. One is I think the WPC has always emphasized the non-motor aspects of Parkinson's disease, which is near and dear to my heart because that's what I focus on. So psychiatric and cognitive and other complications. And I think it's really a wonderful venue for people like me that see patients, but also are asking questions and trying to learn about the illness and understand it to lead to better management strategies to interact with patients and their family members and loved ones to understand the experience. So to me, it's always been a wonderful meeting. The slides that are here, you can see the logo from the WPC meeting in Barcelona in 2023. That was because the first time I presented this specific talk was there. I did update the slide some for today, but I just left the pretty pictures of Barcelona on the first slide. But of course, the next meeting's in 2026 in Phoenix, Arizona. Okay, so I think we can advance the slide now. These are disclosure slides. I will say that I'm only seeing this in the upper right-hand corner, so I'm doing my best. I don't know if I should be seeing it in a different format. That's a question for the people. If I should, let me know. If not, I'll just operate off of this kind of third of the screen that I can see, upper third, upper right. But anyway, these are my disclosures. I don't need to go through them in any more detail. They're available. And next slide, please. So this is an introduction slide. Next. So there's this whole notion when thinking about neuropsychiatric symptoms in Parkinson's disease, or psychiatric and cognitive symptoms broadly, that's what I'm calling neuropsychiatric symptoms, about what's the impact of the disease versus the impact of the Parkinson's treatments. And today, my assignment is to focus really on the impact of Parkinson's treatments, which is certainly relevant to people with young onset Parkinson's disease. But first, we have to recognize that the neural substrate, as we call it, or the biological changes that occur in Parkinson's disease are very relevant to psychiatry and psychiatric symptoms in general. That includes the brain regions that are affected, the neurotransmitters or chemicals, the pathways. They're all implicated not only in Parkinson's disease, but in psychiatric disorders as well. We know that patients can develop psychiatric symptoms before their diagnosis of Parkinson's disease, which really, again, highlights the biological contribution because these are people that don't even know they're going to develop Parkinson's disease at this point. And I list a couple of those disorders here. Then we get to the Parkinson's treatments themselves. So once somebody receives a diagnosis of Parkinson's disease, at some point they start treatment, often more than one treatment over time. And these are treatments that primarily, if they're medications, target some of the chemicals that I mentioned before, dopamine, norepinephrine, acetylcholine. And we also know that there's this kind of cross-fertilization between neurology and psychiatry where Parkinson's treatments are used for psychiatric disorders. And that includes things such as selegiline patch. Selegiline is what's called an MAOB inhibitor, and that's approved in psychiatry for treatment-resistant depression. And deep brain stimulation, which was used originally for Parkinson's disease, is used rather broadly within the psychiatric community as well for disorders such as obsessive compulsive disorder. Next. So if we dive a little bit into some of the specific disorders that can arise or are more common in Parkinson's, depression, anxiety, and apathy are what we more broadly call affective disorders. Next. So we know that depression occurs in the prodromal or at-risk state for some people with Parkinson's disease. So if you look back from the time of diagnosis in the period up to maybe 5 years before, there's an increased risk of depression in people who are ultimately going to develop Parkinson's disease. So that does speak to the biology of these symptoms, that it's hitting a part of the brain before it hits the part of the brain responsible for the motor symptoms that's responsible for emotional control, or in this case, mood. Next. Now, fast forwarding to the Parkinson's treatments, which is really my focus for today, we do have evidence that once somebody has an established diagnosis of Parkinson's disease and has a diagnosis of depression, that at least one class of Parkinson's medications, in this case, dopamine agonist, has antidepressant properties within Parkinson's disease. And this is a large randomized controlled trial, kind of the most rigorous scientific clinical trial we have, that showed that patients randomized to pramipexole in this case versus placebo had a greater improvement in their mood, even accounting for their improvement in motor symptoms. And of course, there's 3 dopamine agonists, pramipexole being one, ropinirole another, and rotigotine patch the third in the United States. Next. We also know that MAOB agonists, so the most commonly used MAOB agonists are rasagiline and in the past selegiline, also increase the levels of dopamine in the brain. This was data from a study called the Adagio study that showed that patients who were randomized to rasagiline versus placebo had some improvement in their mood. These are newly diagnosed, untreated patients at the time of the study. Next. However, there was then a more formal trial to test rasagiline for people with established Parkinson's disease and actual diagnosis of depression that was not positive. So the jury is still out, I would say, about the impact of MAOB inhibitors on mood. Next. About 10 to 15% of Parkinson's patients over time will receive deep brain stimulation as a procedure, and there's 2 main stimulation areas of the brain, the STN or subthalamic nucleus versus the GPI or globus pallidus interna. I think the animation on the slide isn't working out exactly, but what I'll tell you is the content of the slide is there's been some evidence from studies that perhaps the GPI has a preferential effect or a better effect on mood after DBS versus the STN, but there's other research that suggests that there really is no difference between these 2 locations. But there are some neurosurgeons, when they're considering which placement to choose for the stimulation for the electrodes, will consider a person's psychiatric state prior to the surgery. Next. For a long time, there was some concern that deep brain stimulation might be associated with suicide. This was mainly from suicide ideation or suicide attempts or even suicide completion. This was from an early series that looked at a number of patients who were really followed for quite a long time after surgery, like almost a decade, and found that there were several people who had committed suicide and that they felt that that showed an increased risk with deep brain stimulation. But I thought that literature was somewhat limited. And since then, I don't really think that research has borne that out to be true. And next slide is one study where we attempted to look at this was this in the Department of Veterans Affairs called the CSP 468 study, where patients were randomized to deep brain stimulation or what's called best medical therapy. And over the first 6 months after the surgery or maintaining best medical therapy, there was really no difference in suicide ideation between the two groups, and there were no suicide attempts. So I think when you do more formal controlled research, the results don't suggest that GBS is associated with an increased risk of suicide. Next. Another issue that comes up, I'm sorry, all of the animations are not working here, but I could talk you through this. That there's something called serotonin syndrome. So for anybody who's on an antidepressant, and the most commonly prescribed antidepressants are SSRIs, selective serotonin reuptake inhibitors, or co-prescribed an MAO-B inhibitor. I've already mentioned that those are rasagiline and selegiline. You'll bring up a red flag from the pharmacy about the possible interaction of what's called serotonin syndrome. And if this occurs, it's quite a serious syndrome where people have mental status changes, neurological symptoms, and it really requires prompt emergency treatment. And that's whether you're on an antidepressant and are adding an MAO-B inhibitor, or you're already on an MAO-B inhibitor and you want to add an antidepressant. What you can't see on this slide is that we looked at this study that I mentioned before, the Adagio study, and there were about 100 people that were on rasagiline and an antidepressant for the first 6 months of that study, and none of them had evidence for what we call serotonin syndrome based on the adverse event reporting for this study. So if serotonin syndrome occurs, and I'm sure that it can, it seems to be quite rare with this particular interaction between an antidepressant and Parkinson's medication. Okay. Next. So apathy was one other affective disorder. So apathy is a loss of motivation, and it can be manifest in various ways. But this was evidence from a study of people undergoing deep brain stimulation who had their dopamine agonist discontinued after treatment, after surgery, that a number of them became quite apathetic when they had their dopamine agonist withdrawn. And then they did a clinical trial where they were either randomized back to their dopamine agonist or to placebo. And it showed that those that were put back on their dopamine agonist had an improvement on their apathy. So it does suggest, at least in a subset of patients, that dopamine agonists can have anti-apathy effects. But this may only be to the subset of patients that I was describing that had undergone deep brain stimulation, because there was another study more formally targeting apathy in Parkinson's disease that was negative using a different dopamine agonist. Next. So in terms of clinical management of these disorders, there's some evidence that dopamine agonists have antidepressant effects and anti-apathy effects. There's evidence that antidepressants that target other neurotransmitter systems affected in Parkinson's disease work. I'm not presenting that because they're not Parkinson's medications, but we have multiple positive studies for SSRIs or serotonin antidepressants, and also for an older antidepressant class called tricyclic antidepressants that targets a different brain chemical, norepinephrine. Next. Psychosis is another syndrome or disorder that can occur in Parkinson's disease. These are primarily hallucinations and delusions. Next. So there is some evidence now that minor psychosis symptoms can occur even in people that are untreated, newly diagnosed with Parkinson's disease. So those are people that may experience something in the periphery of their vision, either a person or something moving, or may misidentify an actual object that's in their visual field. This study did demonstrate that some people who are untreated with Parkinson's disease can experience that. Next. But what we found, again, apologize for the graphics here, is that from a study called the PPMI study, or the Parkinson's Progression Markers Initiative study, where people are untreated at diagnosis or at study entry, is that the rates of psychosis are quite low in Parkinson's disease patients, and similar to the rates that you see with the healthy control group in the study. But what happens over the first few years of the study is that the rates of psychosis go up in Parkinson's disease, and they stay level or steady in the healthy control group. And the main difference is that dopaminergic therapy or Parkinson's medications are being introduced over the first few years of the study, and it's those patients who have Parkinson's medications introduced that are most likely to develop new onset psychosis. Next. The relative likelihood of Parkinson's medications to induce psychosis, really any of them can, I think, in vulnerable people. Vulnerable be those that are older, or those that have cognitive impairment, so memory impairment, for instance, are more prone to develop psychosis as a side effect. But dopamine agonists and what are called anticholinergics seem to have the greatest effect. And anticholinergics are not commonly used anymore. But those include things such as benztropine or trihexyphenidyl, and they are still occasionally used by people with Parkinson's disease. Next. So in terms of managing psychosis, there's expert recommendations about which medications should be discontinued first. This is Parkinson's medications if somebody is experiencing psychosis. And at the end of the day, what typically happens are that the top 4 rows are discontinued, and then patients are managed just with levodopa if the psychosis symptoms have not improved. Next. We have one FDA-approved antipsychotic for psychosis, and it's called pimavanserin. It's been around for close to a decade now. And the point I bring this up is it's not one of the Parkinson's medications, it's a psychiatric medication, but I've spent time talking about the dopaminergic effects and its impact on psychosis, yet pimavanserin does not affect dopamine in any way. It affects only the neurotransmitter of serotonin. So it has kind of a unique mechanism of action where it still has antipsychotic effects, but it's actually not targeting dopamine. Next. So in terms of clinical management of psychosis, nearly all PD medications can potentially cause psychosis, particularly in older patients with cognitive impairment, and that antipsychotics that target the serotonin system versus the dopamine system are the preferred medications to use in PD. And that's not only pimavanserin, but other ones that have more of an effect on serotonin versus dopamine, what are called atypical antipsychotics, because those are thought to affect the motor symptoms of Parkinson's disease less. Next. Moving on to cognitive impairment now, which is a significant concern for many Parkinson's patients. Next. So in terms of Parkinson's medications and their effect, there really is no known differential effect in terms of which medication you start when you're newly diagnosed and if you're followed long term. So this was a study that looked at 2 types of ways of looking at medication. One was whether you started levodopa versus non-levodopa. And then the second was, if you didn't start levodopa, did it make a difference if you started a dopamine agonist or an MAOB inhibitor? And in terms of cognitive outcomes, none of these medications had a better or worse effect compared with the others. So whether you start levodopa, a dopamine agonist, or an MAOB inhibitor, years down the road, the likelihood of cognitive impairment was the same. Okay, next. There has been interest in whether MAOB inhibitors, just as I mentioned, one had been tested for depression and Parkinson's disease, also whether boosting dopamine levels might improve cognition. So this was a study that looked for the treatment of mild cognitive impairment. So that's some degree of cognitive changes, but not severe enough to meet criteria for what we call dementia. So mild cognitive impairment, and the introduction of an MAOB inhibitor did not improve cognition in this study compared with inactive or placebo treatment. Next. Colleague at University of Pennsylvania, Dr. Allison Willis, is an epidemiologist and has spent a lot of time looking at different medication use in large data sets such as Medicare and Department of Veterans Affairs databases. and has found that the use of potentially inappropriate medications, and an extensive list is listed here, may be present in Parkinson's disease. And I highlight this because these are not core Parkinson's medications, but other medications, psychiatric and used for medical conditions, that may be on a medication that could be potentially harmful from a cognitive standpoint. So I think this is worth noting for people, and kind of having lists like this handy and being able to discuss with your physician to make sure you're not doing anything to harm your cognition by being on a medication like such as these. Next. In terms of deep brain stimulation, there's been some sense for a long time now that people that undergo deep brain stimulation, a subset of them, maybe 15%, have kind of an appreciable decline in their cognition in the 6 to 12 months after the surgery. More recent studies that have looked at people getting DBS in an earlier stage of the disease or younger Parkinson's patients seem to conclude that it's actually pretty well tolerated in that group. So the earlier studies tend to have more advanced people, long-standing Parkinson's disease, older patients, and those are more cognitively vulnerable anyway. So it seems like the DBS, at least in younger patients, seems to be well tolerated. Next. So clinical management in terms of cognition, I would say there's no evidence that which Parkinson's medication is started or added over time has differing long-term impact on cognitive outcomes in Parkinson's. Anticholinergic medications may be particularly problematic. Those are both the anticholinergic medications that are used to treat Parkinson's, but other over-the-counter medications that are used, for instance, as sleep aids or antihistamines that also often have, or urinary control medications that have anticholinergic properties. Polypharmacy and higher doses are likely to be associated with confusion. So the more of these medications you're on, or the higher the doses, just compounds the problem. And DBS is more likely to be associated with cognitive changes in patients who are older with more advanced disease, or who had pre-existing cognitive impairment before the surgery. So that's why most surgical teams will do detailed cognitive testing prior to operating on someone. Next. Impulse control disorders. Next. So these are disorders primarily that revolve around 4 main behaviors, although it can manifest any number of ways. So these are compulsive or increases in gambling, buying, sex, or eating behaviors, but it really can be any behavior that's done to an extreme. And this is a slide that shows data from, again, this Parkinson's Progression Markers Initiative study, or the PPMI study funded by the Michael J. Fox Foundation, showing that if you look at untreated patients with Parkinson's disease before they ever start medications, their rates of these ICDs, or impulse control disorders, are no different than healthy controls. That it only happens once the medications are introduced. And if we go to the next slide, this was data from a large study in over 3,000 Parkinson's patients in the United States and Canada that showed that the greatest risk for having an impulse control disorder was dopamine agonist treatment. So I've already mentioned that class of medication before, but we found out that even levodopa has an effect. It's not as strong an effect as dopamine agonists, but it seemed to have an effect, particularly at higher dosages, in contributing to these behaviors. And next. And other studies have shown that other Parkinson's medications also slightly increase the risk. So amantadine, which is used primarily to treat dyskinesias, and I've already mentioned rasagiline several times now, that's an NAOB inhibitor. So really, my conclusion is that any of the Parkinson's medications can potentially contribute to this development of an impulse control disorder, although the risk is clearly the highest for dopamine agonists. Next. There was some question, and it's unanswered still, about whether long-acting dopamine agonists are different. And this is an incredibly busy slide because it's meant to have animations where you wouldn't see it all at once. But this was a study of a large number, close to 1,000 Parkinson's patients from Europe, primarily, who were treated with rotigotine patch in an open label fashion. And the rates there over time, over many years, seem to be lower than what I was reporting from previous research. It did seem that at higher doses, the risk went up. So there does seem to be a dose effect, which has also been shown for other studies of dopamine agonists. And then finally, what the red columns in the bottom are meant to illustrate was that the time of onset, the average time of onset for developing one of these problems for those that did after the introduction of the reticotine patch was about 4 to 5 years. So these problems may not arise immediately, and if you're being followed clinically, it's something you need to be mindful of for as long as you're on a dopamine agonist. Next. This slide, again, a complex slide with layering, is really demonstrating that one of the core strategies we use for people that are appropriate from a motor standpoint and have an impulse control disorder is the introduction of deep brain stimulation. And the reason for that is that if deep brain stimulation is successful, one of the outcomes is that you're on less Parkinson's medications afterward. And if you're on less Parkinson's medication, particularly less dopamine agonist therapy, then the likelihood is that if you have an impulse control disorder, those symptoms will improve afterwards. And that's what this slide demonstrates. Next. There has been more recent literature about some people developing impulse control disorders after deep brain stimulation. So they didn't have it before and they only have it afterwards. And I've been doing this for a long time now and I've seen many patients. And I remember one patient who I thought really developed this as a new problem after surgery. And my only conclusion, and this is kind of a guess, I guess, is that it has to do with the post-operative dosing, that for patients who may not be able to decrease the dose of the medications and remain on the same amount, plus then have deep brain stimulation on top of that, that seems to fit the picture of somebody who may develop a new onset impulse control disorder after surgery. Next. So clinical management for this is that all Parkinson's medications have been associated with impulse control disorders. The strong effect is for dopamine agonists. It's not clear at this point if long acting, so long acting can be, so it's once a day, which can be either oral or patch, but it's less likely it's not clear if those are less likely to cause impulse control disorders. Deep brain stimulation overall leads to a decrease in ICD symptoms, but new onset cases have been reported. It may have to do with the postoperative dosing, and there's also different areas of the brain that can be stimulated, different regions with a DBS, and some are more linked with emotional regulation, so that may play a role as well. Changing Parkinson's medication usually helps, but there is a syndrome that's been described called dopamine agonist withdrawal syndrome, or DAWS, where patients who are on a dopamine agonist and have an impulse control disorder can go through withdrawal symptoms when they're coming off it, which can be quite uncomfortable for them. Next. And finally, the category, this is the last disorder to discuss, called non-motor fluctuations, or yes, and I'll describe what that is on the next slide. So those are non-motor symptoms, not motor, but non-motor symptoms that occur as patients are in the off state as their Parkinson's medications wear off. Typically, it's the levodopa we're talking about. So some of you may have heard of these off periods. And these off periods can not only have motor symptoms, but they can have non-motor symptoms. And in this original study that really described this syndrome, they asked 50 patients, Parkinson's patients, who had motor fluctuations about other symptoms, non-motor symptoms, and all of them declared that they had had some non-motor fluctuations in addition to motor fluctuations. So as their medication was wearing off, and if we go to the next slide, it describes in detail what symptoms were most commonly reported. So anxiety is a common non-motor fluctuation, slowness of thinking, fatigue, irritability, even hallucinations. Although those are less common in the off periods, they're more likely to be in the on periods from the heightened dopaminergic effects. Next. So in clinical management, the Parkinson's doctors, the ones that are actually managing the motor symptoms, have a range of options available to supplement the levodopa that people are typically taking to kind of smooth out the dopamine levels and to minimize fluctuations. Sometimes patients, again, will undergo deep brain stimulation because they'll be on less medication that way afterwards. We do sometimes use psychiatric medications, for instance, antidepressants and anti-anxiety agents, but we don't really have good evidence that they help with these non-motor fluctuations specifically. Next. So here's the, I think this is my last slide, the key takeaways from the impact of Parkinson's treatments on neuropsychiatric symptoms. There's possible adverse effects from some of the Parkinson's medications, and those would be primarily impulse control disorder, psychosis, and over time, the development of non-motor fluctuations with chronic levodopa treatment. There's possible benefits, so they may have mood-enhancing effects, anti-apathy effects, or even impulse control type symptoms that are not harmful, but actually some people find beneficial, such as increases in creativity. And this would primarily be for dopamine agonists. So different medication classes have different effects. The impact of deep brain stimulation appears to be variable, but overall, in terms of psychiatric symptoms, I'd say it's beneficial, and for cognition, maybe a slight decrease on average, and that there's certain patient level characteristics that predict adverse events, such as younger age being more likely to develop an impulse control disorder, or older age or cognitive impairment being more likely to develop psychosis as a side effect or cognitive impairment. So I think that's the last slide. If we just advance once more, just to make sure there's nothing else. Yeah, so I think we got through everything.
Great. Thank you so much, Dr. Weintraub. This is such a detailed and comprehensive look at all the different, medications and treatments and their potential benefits and kind of negative impacts that can happen. We had a couple questions from the audience, and please feel free to hop in with your questions, and I'll try and present them as time permits. But I wondered if you knew, you had said that the rate for DBS among all Parkinson's patients was about 10 to 15%. Do you know if that's different for young onset for YOPD folks? Is there a higher rate of folks having DBS on with those diagnosed earlier, or is that not known?
Well, I think if you follow a young onset Parkinson's patient for long enough, they become an older Parkinson's patient, and there
True.
they would be falling under that same category of 10 to 15% overall. It's just they're probably not going to be having it at age 45 or age 50. That would be more unusual, I think. So I think,
I don't like having to fall under that category, but I do because I'm 50 and just had it 3 years ago.
yeah, so it does occur. I think it's typically people, and traditionally, I should say, not typically, traditionally, it's been people who have been older and have long-standing disease. Now, you can be 50 and have long-standing disease, so that would make you more likely to have it. And I think the good news is that if that is recommended and it makes sense because of side effects of medications or not working well, I think a young person who's cognitively intact is likely to tolerate the surgery very well.
Hmm. Great. Hopefully I qualify as cognitively intact. Well,
I think so. I think so.
Um, so I wanted to ask you two questions. One is about what the Produodopa pump, the new pump that came out that's sort of similar, I think, to like an insulin pump, and that I don't know if you're familiar with that, but is that, I know that's sort of newer in the space. Is that how can we think about that in terms of kind of interactions with the other medications that you might be taking, et cetera?
Yeah.
Can you
So I mean,
describe it a little bit, actually?
sure. So there's actually the original Duopa. So that was through the gastrointestinal system and involves, more elaborate procedure and working with a gastrointestinal doctor. And now there's the more recently approved subcutaneous levodopa, carbidopa, that's kind of a modification of that. But what's in common for them is that they're really aiming to do kind of more of a 24-hour delivery, constant delivery of levodopa, as opposed to kind of the pulsatile oral administration where you're taking it every several hours or so. So I think the hope is that by smoothing out the levodopa dose, you'll have less fluctuations, and potentially those less fluctuations, but not only be less motor fluctuations, but less non-motor fluctuations. And so I think the preliminary research does suggest that it's helpful for non-motor symptoms as well. In terms of its impact on like major depression or impulse control disorders or psychosis, I think it's not known if it has benefit in that regard yet. We need more time to really evaluate that, like more chronic exposure. Often these short-term trials aren't really able to address all of these issues. and they really focus primarily on the motor symptoms when they're looking to have these medications approved.
Right. Yeah, I mean, and this is a heavier topic, but I wanted to talk a little bit more about the incidence of suicide and death by
Mhm.
suicide, and whether that is more common among younger onset folks, or is there not a difference between those two?
Yeah. Well, just kind of stepping back, when I first came in, I think it was to this field, which is over 20 years ago now, it was assumed that Parkinson's might have a higher risk of suicide. But then
Mhm.
the early literature didn't really suggest that at all. And people hypothesized that maybe because there's changes in motivation or there's certain motor limitations or
Mhm.
any number of kind of hypotheses about why that might be true. And I must say, again, drawing from my own clinical experience of having seen many people over many years now, that my knowledge of patients committing suicide or attempting suicide is it's quite low. There have been some more recent studies that look at like 1 million people in a database and compare those with Parkinson's versus those without and show a slightly increased risk. But those are studies it's hard to draw many conclusions from. And even in those studies, the incidence or the likelihood is quite low. It's very rare.
Yeah.
Um, Now,
I mean, I
to
think
then go,
important to mention that if you are ever feeling that way, there's so many different places to reach out to, how, hotlines, et cetera. But that there's also, I think, the strength of the Parkinson's community, which comes through in the WPC, which I'm a big fan of personally. But that there, for me, there's always someone to reach out to across the world who's awake when I'm awake, because we all know Parkinson's can cause sleep problems.
yeah, yes, yeah, and you're tackling a whole different side of it. I was just presenting the data. You're presenting kind of the human element and the management, which is obviously very important. I mean, there's a national suicide hotline in the United States, and I do think there's a lot of resources. Your one other point was about, or question was about young onset. I don't think it's known if people who have young onset are more likely to experience suicide ideation than older people. When we did examine this issue, this is the last point I'll make. We found that people might have death ideation, like kind of a sense of hopelessness or helplessness, or feeling like life might not be worth living. Those kinds of thoughts were more common than an actual thought about, taking one's own life or harming
Huh.
oneself.
Huh. I found for myself, just on a personal note, that can happen when I'm feeling more off, like you were talking about the non-motor fluctuations, that when I'm feeling more often, sort of that leads me to feel more hopeless and helpless if I can't really do what I want to be doing, even if I have lots of plans. But that the sort of inability to do so is very frustrating and can leave me feeling more down.
Quite impressed by had the impact of non-motor fluctuations. You're describing one end of it. The ones that are most memorable to me are actually the people that develop these kind of crippling, disabling anxiety attacks as their medication's wearing off. So these non-motor fluctuations can be quite powerful.
I think it's so important to know about them too, because for me at least, one thing that helps me is knowing that they'll pass, right? Once my medication kicks back in, I know that that those will, the feelings will subside. Whereas, if it's just sort of free floating and I have no idea why it's happening, it can be a totally different experience.
I agree. That's a good point.
Um, I was going to ask you if you could say a little bit more about the DAWs and what the dopamine agonist withdrawal
Yeah.
syndrome and what that looks like.
It's interesting because that was described, once we figured out that the most effective way to treat impulse control disorders was to get people off the dopamine agonist, because it really does typically make the problem go away. But if
Mhm.
you do it kind of abruptly from a higher dose, particularly, and to off the medication pretty quickly, people can experience this syndrome, and it really has, multiple components. It has kind of a psychological or cognitive component where people just feel bad. They feel upset inside, worried, and it has a physiological component where they actually feel like they're withdrawing. They get stomach upsets, sweatiness. So it's almost like any substance where your body and brain gets used to being on it, and then you abruptly or quickly take it away. You go through both a behavioral and physiological withdrawal syndrome, and it can be quite uncomfortable. And it's typically relieved if somebody goes back on the medication. But the problem is being back on the medication means they may also have the impulse control disorder. So
I was trying to balance these two pieces. Is there a kind of a way to taper
You,
this? And,
you can do a tapering. People try all kinds of things. They try to taper, they try to maybe not discontinue it, but just go to a lower dose. Some people have even tried going to a different dopamine agonist. As I said, there's 3 of them. So maybe you didn't tolerate one, but you could tolerate another one. Some people go up on the levodopa dosage to compensate. So you're getting more, not getting less dopaminergic therapy overall. You're just getting less of the dopamine agonist, but more of the levodopa. All of these strategies are tried, but there's really very little evidence to suggest whether they work or not,
okay, so more research needs to be done, clearly.
for sure.
Um, and then in terms of the impulse control disorders, you said, yeah, I think you mentioned something about them being more likely in younger folks. Can you say a little bit more
Yeah,
about that?
there has been some research that younger people, particularly younger men, may be more predisposed to that. That's been reported in several studies. Um, there's other predisposing factors. So if you have a personal history of one of these, like prior to Parkinson's, it makes you more vulnerable. If you have a family history, it makes you more vulnerable. If you have a substance abuse disorder history, that seems to have an impact. And then some of them have differential sex effects or gender effects, but and that they mirror what's true in the general population for these disorders. So gambling doesn't seem to really differ between men and women, but sexual behaviors are more common in men, and eating and buying behaviors are more common in women. But that reflects what's also true in non-Parkinson's patients with these problems.
Interesting. Great. And then there was one other question I had. Are there any kind of upcoming medications or other things that you're really excited about in this space?
Well, I would say maybe. There's lots going on. I would say, because I kind of have a view of the field. And I'd say most of the research in the areas that I was presenting are really focused on cognitive impairment, I would say. So the treatment of mild cognitive impairment or dementia using a variety of mechanisms, some quite novel. So I think that's really good. I'd say the other disorders, there's not so much going on in Parkinson's. There are some. I will say, like psychiatry, in my lifetime, again, 20 plus years as a psychiatrist, is going through an explosion right now in new treatments. I'm not talking about psychiatry and Parkinson's, but psychiatry in general. For many, many years, we were using the same antidepressants or the same antipsychotics or variants of them, and that was all that was new. Now, in the past 5 years or so, there's all of these new mechanisms that are being explored in medication wise. There's many kind of stimulation techniques that are being used, transcranial magnetic stimulation, transcranial direct current stimulation, and so on. So there's just like an explosion. And I think some of those eventually may have applicability to Parkinson's. So for instance, ketamine is approved for the treatment of severe depression, and S-ketamine, which is its nasal spray variant, is also approved for depression. There's now a few ketamine studies ongoing for depression and Parkinson's disease. So we'll learn in the coming years if those are effective treatments. But again, I'd say most of the treatments focus on cognition. And the final point I'll make is, as people know, the field is trying to not only develop symptomatic therapies, but disease targeting or disease modifying therapies. And the hope is, if you're targeting, for instance, something like synuclein aggregation or Lewy bodies, as we call them, that if you're able to impact on that in some way, not only will that help the motor symptoms, but it should also help with the non-motor symptoms I'm talking about, because they're part of the same disease process. It's not like it's a separate disease.
Right. How do you suggest that people find someone to work with, psychiatric experts who know about Parkinson's and can work with YOPD folks?
Good luck, I guess I would say. I
It's
mean,
not easy even to find a therapist or a psychiatrist, huh?
probably easier to find a therapist. So by therapist, I would be referring to like a psychotherapist, which are typically social workers, psychologists, other types of professionals with psychotherapy training. That's probably a little bit more easy, although I wouldn't say easy to find one with expertise in Parkinson's unless you're at a major, academic center. That's not likely to be common. Finding a psychiatrist that has any experience with Parkinson's is just very hard to do. So really, you would, because there's just not many people that do this. Um, there's just not many geriatric psychiatrists in general, much less geriatric psychiatrists that work with Parkinson's, because most Parkinson's patients are older, they're not younger, most of them.
Mhm.
Um, so I think you'd be looking for maybe somebody who would bill themselves as a geriatric psychiatrist who would have experience with neurological disorders, or a neuropsychiatrist as they're called, or just a good, competent adult psychiatrist.
Yeah. I found in my experience, that if I find someone that I like, a psychiatrist or a therapist, I can help educate them to some extent or
Yeah, I
interest them
think
in
that's a
getting
good point.
involved.
It's
Because
such
it
a
is,
yeah.
sorry, go ahead.
No, you go, Beck, I didn't mean to interrupt you.
No, I was just saying that because it is hard to find someone who's specifically trained or has experience working in this area, but if you find someone you like, at least you know you like them,
Yeah.
which would be so important, just to have that relationship with someone.
I think your point is a good one, and I just want to echo, how complicated the illness is, and it took me forever, it felt like, to learn the basics, and I'm still being surprised, every day. We say it all the time, but it really is true that every patient is different, and you just are constantly learning something new, and the treatments evolve, and new treatments come out, and there's good parts to the new treatments, there's complications to the new treatments, and it's just endlessly complicated, I would say, Parkinson's.
Yeah, I mean, I think for that reason in particular, it's good to find someone you can really partner with and then go on this journey together.
Yeah, I agree. Yeah.
Um, well, I think that's about it in terms of the questions, unless there's any others. Thank you so much for your time and expertise in this, Dr. Weintraub. It's really been great having this conversation with you. Just a few things as we wrap up, just to let everyone know that all these talks have been recorded and will be available for viewing next week. And we hope that you'll share this information with friends or support groups who might like to view these talks on their own time. I want to thank again to Mitsubishi Tanabe Pharma America for supporting this program. We really, really appreciate their support. And to just make another pitch before we sign off, to invite you to save the date for the 7th World Parkinson's Congress that will run from May 24th to 27th in 2026. And this time we're going to be located in Phoenix, Arizona, sunny Phoenix. So it only happens every 3 years, so don't miss it. Put it on your calendar. There's so many great people there to meet, people you might already know from social media, other places. Dr. Weintraub will be there. I will be there. And we hope to see you there. So thank you so much.